Sahel Teaching Hospital, Artificial Intelligence and Machine Learning in Vascular Surgery. Whatever and how.
بسم الله.
الساحل يا دكتور شرفنا بالساحل.
الله يخليك. بسم الله الرحمن الرحيم. Thank you very much for the very kind invitation, and I hope to run very quickly about my experience. I'm Dr. Mohamed Omar Farouk. I'm a consultant vascular surgeon and also examiner in the Royal College of Surgeons of England. This is one of the congress that is very near to my heart, speaking about artificial intelligence. I think it's a great success to my dearest Professor Dr. Ahmed Essam to arrange such a great congress about AI in this particular time in Egypt. I'm going to speak quickly about definition of AI. You already have seen a lot of the slides. How AI programming is done, and you can do it free. You can do it today if you want. And example of some AI in aortic surgery, which is the surgeries that I do, and I will go to quick conclusion. Artificial intelligence, by definition, it's a capability of a machine to imitate intelligence of human behavior. This is what we all know when you do Microsoft Word. You get the prediction of the next word. When you are doing driving, GPS, all this we deal in our life day in and day out. I wouldn't go into further detail about the types of AI. AI depend on a computer language, which is called Python. And Python language, you can learn it within 1 hour. If you read this book, which is free over the internet, learning Python language in 1 hour. You don't need to buy a computer to do programming, because now Google have a Colab, which is a facility that it will give you a supercomputer, a CPU which does not deal with just a small amount of data. It's called gigabyte processing unit. And even terabyte processing unit, what's called TPU. TPU costs something like $200,000 US. It's free. Not only this, but it will give you 100 gigabytes of RAM. It's free. So if you want to do computer programming using Python by today, you can do it. You don't need a computer, you don't need a supercomputer, and you can use the TPU facility, and Python is really very easy to learn. And it is free. This is Google Colab. This is my account, and you will find a lot of software that is being used for vascular surgery. And again, it's a very basic language. And when you got some software, you have to join what is called GitHub. GitHub is where open programmer put their data and put the program. It's a kind of open source, so all our programs can be used by others and vice versa. Now there is a special AI to form programming, which is called Divine. So either Divine or Black Box, you tell them, I want a Python programming to detect endoleak in aortic aneurysm type 2. It will give you a hint what to do. It will give you the parameters. And all I'm speaking about is totally free with charge. You don't pay anything. If you notice that a ChatGPT, to give you this information, they pay $3 million US per day just to keep up the data. Because when you put the question into an AI, you get a huge amount of data. And this is how you start programming. And I've done a course for vascular surgeon, how to do AI programming in vascular surgery. By law in United States, every medical student year 1 should have AI training. I am one of the trainers in Toledo University in Philadelphia, and we usually meet every month to detect what is the AI programming, and I am impressed. They are first year medical school, and 1 in 4 of them have already started to open company. Start to do programming. They are brilliant. They are one of the best brain-wise. And to start AI is free. You can do it to any university in Egypt. And I really very much impressed with the AI pushing in Suez Canal University. And I really congratulate such amount of work. So this is one of the meetings that we were sitting and we were discussing 3 programs new that we're discussing them. And because I used to be computer programming, I'm helping them with decoding some of the defect in the programming. And now let us speak about aortic surgery in my specialty. And I will be very simple. AI can help you pre-operative, intraoperative, and post-operative, all the three. And I will speak about something not in the future, but something existing. So this is what has already been done in 2024. So pre-operative, you can detect by AI the growth of your aortic aneurysm. And you can detect by AI when it is going to rupture. And you can detect with AI your mortality. So can you imagine if I am in the clinic in Switzerland and a patient came to me, and this hospital have an AI, then patient came to me with 4 centimeter aortic aneurysm, I will tell him, well, your aneurysm in 2 years will be 6 centimeters, and at that time you will have rupture within 6 months, and when you rupture, your mortality rate is around 70%. Can you imagine a clinic like this? And this is actually happened now in Zurich, in Schultes Clinic. So this is the AI, how it really revolutionized how you deal with the aortic disease. So this is a paper they publish about prediction of growth. They have very good software. It actually predicts within 1 millimeter your growth rate. And it also predicts your rupture. This is the prediction for the size growth, and this is the prediction for mortality. And it will tell you your mortality. This is very easy. You just take 4 parameters, age and size of the aneurysm and other health issue, and you just make a computer program, very simple, just 4 elements, and this is what is called neural network. Very easy program. It's actually freely available if you are in Zurich to use it, and I use it to my patient as well. But it's not a good news when you tell the patient, well, your mortality rate is so. It actually very accurate in decoding when and where it will rupture the aortic aneurysm. This is a patient with 51 millimeter aortic aneurysm, but you can see the amount of thrombus is different. This is low thrombus, this is high thrombus. You can have what is called the thrombus AI analysis, which will take the thrombus AI and it will tell you the more red you are, the more tension on the wall. So you can see the maximum tension at this point. This black point is the maximum tension. And this is when you rupture. Here, AI save your life. And that's why it's very important. Because a hospital with no AI, patient will die. And if you're working and living in another country where they use AI, you've been saved. And this is huge. And they actually, by the way, they said, the speed of artificial intelligence, by the year 2047, it will solve the question of death. What does this mean? If you get all the data of the patient all over the world when they die spontaneously, not post-operative, not due to accident, the ChatGPT will look into all these huge parameters over 100 years, and it will tell you, this is how you can prevent the problem of this. From my religious background, I think this will not happen, but at least there is some paper speaking about this. So actually this patient have rupture at exact point that's been predicted by AI. Not only this, but and also now, this is in Sweden, they have, if you combine artificial intelligence with robotics, so here the AI does not speak to you only, but it has a hand. Well, why not to do duplex scan? This is actually a program, and I will show you even to put a gel in the duplex scan because the artificial intelligence is moving, and then you can put the gel. This is actual machine if you work in Sweden, and you can just put a request, duplex scan done by artificial intelligence, even putting gel, and you can tell them, well, can you follow this intervention with a guide wire and follow with the aorta? It's quite impressive, isn't it? So this is a duplex scan using combination of robotics and artificial intelligence together. Now, this is, if you go to and visit the Royal College of Surgeons of England, when you go straight to the door, you will see Da Vinci V2. Da Vinci V2, this is the future of surgery, because here you have 10 arms, that can do plenty of things human cannot do. And this is the main entrance of the Royal College of Surgery in England, because they know that future of surgery will be manipulated by robotics. Now in China, due to the very high speed of internet, they can, if you are in Shanghai and you want to do an operation in Beijing, you can do it. They have done appendicectomy because the speed, they put robotic in one city and they're being controlled by another city. So your clinic will be vast, and instead of using just your patient, you can operate in 3-4. This is actually been done also by NASA, because what if one of the astronauts got appendicitis? What you're going to do? You're not going to bring it to Earth. So they got Da Vinci V2 with them up there in the satellite station, and now there are 10 surgeons from the United States Army being trained to do appendicectomy in space. They have no problem with the speed of internet. They can do appendicectomy, get him better, everything is fine. It's been done in practice in the United States before the astronaut go up there. So this is definitely the future of surgery, is the robotic arm. Now, intraoperative, you can detect endoleak. This is one of the software. This has been done in Belgium, because the AI, artificial intelligence, does not look like our eyes. It look at the pixel. So it's not that the rupture up there on the right-hand side, you're not concentrating on focus. AI doesn't have a focus. Every image consists of pixel, which has been seen by AI. So it was found that it detects endoleak type 2 a lot better than us. So post-operative, it can also tell you, well, this patient will need ultrasound in 6 months, CT scan every year. After 5 years, you will need to finish his follow-up. So this is also by artificial intelligence, and this is actually done by Google Gemini. If you put Google Gemini, the post-operative angiogram of your patient, it will tell you the post-operative follow-up. It's quite impressive. It is free and also available in Egypt. I have done this course, which is free artificial intelligence course to vascular surgeon, teaching them how you can learn Python language. It's easy, open source, not far away from English, and you can learn it within 1 hour. And by this course, which is, if you go to YouTube, you are very welcome to join because it's free. We have 2 programs, one that detect COVID-19 on a chest X-ray, and the other programs that detect pneumonia on a chest X-ray. It's just 10 line coding, not more than this, and anyone can do it. So my conclusion, artificial intelligence sure will play a role in vascular surgery and all other field of development, and we can use big data with a larger processor power, and it will improve definitely our medical knowledge improvement and medical services. And we all must use AI at least every day. So I would like to finish with this comment of mine. AI will not take your job, but doctor who's using AI will take your job. And thank you very much.
Excellent presentation. Now with the Dr. Wael Saar, أستاذ دكتور وائل صقر، المحاضرة Artificial Intelligence and Plastic Surgery Now and the Future. دكتور وائل صقر رئيس قسم جراحة التجميل في جامعة بني سويف، تزاملنا واحنا نواب في القصر العيني وهو كان السينيور بتاعي. من الناس اللي تحب تعلم جدا الحقيقة، وكان العميد السابق لجامعة بني سويف. اتفضل دكتور وائل.
بشكر جدا زميل الحبيب استاذ دكتور محمد عبد المعطي رئيس قسم الجراحه العامه وجراحه التجميل. بشكر دكتور احمد السقا لدعوتي، واشكر دكتور احمد الصرفي لدعوتي للمؤتمر. I was very impressed بصراحه بالمؤتمر في توقيت رائع ان شاء الله. هنتكلم عن ال AI in plastic surgery. الحمد لله انا استفدت كتير من المحاضرات اللي قبلي، هتوفر لي كتير من الوقت. احنا مش هنعدي كتير في التفاصيل. we'll go. The main question which will be asked every day, there will be no more role for plastic surgeons. We will ask This is the triad of clinical teaching, of the decision making, the clinical expertise, best research evidence, and the patient values and expectations give us the clinical decision making. But AI is trying to override this clinical expertise. We will have later on. What's AI? I will not go through because it was done. For me, as a plastic surgeon, when I see these pictures of noses in rhinoplasty, this one with with the depressed nose and the cleft lip and palate, this lady with the hump of the nose, and this man with old fractured nose and deviated and crooked nose, and this one with severely deviated nose. So all these photos come to my mind and I do processing, as my colleagues said before. This is mind processing, so to give a decision making. So how we are going to learn the machine to do this processing. The machine is doing this processing from collection of data until the output, which is the clinical decision making to what to do for this patient specially. Current development in artificial intelligence in plastic surgery, we are still in the proof of concept delay, but as Dr. Sarafi said yesterday, it is increasing magnificently and very speedy. In plastic surgery, we have some registries as a National Breast Implant Registry and tracking operations outcomes. These registries are the collection of data all over the world, which will be of beneficial use in AI. We are using AI in providing burn care patients and detecting skin cancer. This is how the photos and the applications see the photo of the skin tumor, and it will say this may simulate either basal cell carcinoma, squamous cell carcinoma, or even malignant melanoma. I know that this will not override the rule of the biopsy and the pathology, but it will give accuracy more than 99%. This is also a model done by Markov decision process in the reinforcement of keloid treatment, either by silicone, by medical treatment, by surgical treatment. This is one of huge cases. Trauma of the lower limb, the bone was exposed. This patient was going to have amputation of his leg. We take a free flap for him. This free flap with a blood supply. So this application is to monitor the free flap for 2 or 3 days. This application is with the nurse, with the resident, and with the consultant. And the early detection of tissue perfusion, they call the consultant immediately to repair this issue. Also, there is a model for diagnosis of congenital disease in the child. And this is our colleague from the United States said that radiology we are treating with maxillofacial fractures. This was one of my conferences I attended, and I can see with this lens a 3D picture moving. I can move it by myself to see the bone from inside and from outside. Also, we are dealing with tumors of the maxilla, adenocarcinoma of the maxillary antrum. That's why the photo we said was the virtual reality, and here we use the augmented reality to take a good safety margin for the patient. This is the tumor of the maxilla. The lens, by the augmented reality, I see intraoperative photos, and right as you see in this blue lines, this is the safety margin. I'm going to remove it, and I can remove it and put an implant inside using this way. Mobile applications also, this is the photo age clock. The photo age clock look to the eye of the patient and the wrinkles around the eye and give me approximate prediction of the age. This is artificial intelligent virtual assistant, like Siri in our mobile phones. It can answer questions on behalf of the doctor to the patients. And the study said that this IVAS application give answers with accuracy from 80 to 90% of the patients. He can, instead of using a human secretary, it can answer all these answers and questions. This is the circle of the patient, the life cycle of the patient, and how AI help us. Help us first on diagnosis, preoperative consultation, also in diagnosing by images, as we said, so in the human, in the skin tumors. In surgical decision making, as Dr. Omar Farouk said, it is AI robotic assisted surgery. We will see it, and it can predict the wound healing that we will see in the burn and follow up of the patient. Also, we can use AI in burn management. AI can assist the clinician to know the surface area of the burn and the burn depth, which is a very important area to use. And this is the publications that the PubMed related to the AI in plastic surgery in the last years. It is increasing exponential. This word I borrowed from Dr. Sarafi yesterday. He said, what's exponential? In 30 foods, he told me that his 30 steps will go us to the moon and come back. Who can take the decision in care? The journey of the patient starts from prevention of burn, emergency room, admission, diagnosis, follow-up, operations, and discharge. These are the steps. First two steps is prevention and community burn assessment. In high-income countries, this prevention and the awareness of the people started to work to reduce the mortality, which is not the case, unfortunately, in low and middle-income countries. In the pre-hospital care, there is an automated system to tell us how to are going, this patient will have some complications. The most common applications of burn machine learning is burn depth and survival and mortality. These are photos of 4 patients with several degrees of burns. It starts from very superficial to very deep burn. The burn depth, evaluation of burn depth, الأول كنا بنشوفه بعينينا نقول ده superficial أو deep. وبعض التكنيكس دخلت like laser Doppler, thermography, differential reflective photometry, ultrasound and optical coherence tomography. The surface area, we are using a sterile film and draw it to know the surface area. Digital camera to say the surface area, burn calculation system, and 3D applications. The complicated and time-consuming part of these methods is to determine the wound region and surface area of the patient and depth. Now, to solve this problem, we started to use what is called segmentation of photos. As Dr. Omar Farouk said, it is pixels. Segmentation of the photos, it is segmentation from framework. It removes the noise around the patient and gives us only the burned area. This is a child with burn. This is burn wound mask. And this gray one gives me what is superficial and what is deep in the center of the burn. Image interpretation versus human judgment by the CNN. This is one of the softwares, and we gave him so many patients. He told me that the upper 2 rows with a total body surface area less than 5%, with a good prognosis, these patients will heal spontaneously. And for the second row, third, and fourth row with a total body surface area more than 20%. Also, segmentation will give me the depth, starting from superficial to deep in the bottom. These are some publications giving us some clue for the segmentation giving us. This is a SATA skin abnormality tracking algorithm, starting from giving the system the image until he gives me the clinical decision at the end of the patient. This is also how do segmentation do for the same patients during follow-up from week 1 to week 7. And in the first row, give me the granulation tissue. In the second row, the pustules. And then the eschar and the epithelialization and the healing in the last row. Remote wound healing, even after the patient is discharged from the hospital, he can take by his mobile a photo and send me and put it inside this software to give me the follow-up of this patient. In the perioperative management, it can give me how to predict healing and the necessity of the patient. Which patient of the burn patients will need skin graft and which will not, which will heal spontaneously. Also, one of the complications of burn is acute kidney injury. It can, with accuracy of 90%, gives us prediction of patient to have acute kidney injury even 60 hours before it happens. And this will differently will affect the mortality of the patients. We will improve the survival of the patients, one of the main causes of death. Post-operative recovery, also it predicts sepsis and the response to antibiotics by so many softwares. The patient during dressing of the burn, it has severe pain. So some softwares give me how can I reduce the pain during debridement or during dressing of the patient. Also, it monitors the progress and physiotherapy of the patient. This is an application called Proximi, and this is cloud-based augmented reality, gives also me the effect of, there are two teams working at the same time to give the same clinical decision for the same patient. And this is the robot Dr. Omar Farouk said, showed us, and these are transatlantic robotic assisted surgery from the United States. We are doing face transplantation in Salzburg in France. These are the futures, I will not repeat it. The limitations also said by Dr. Sami Hashim in his lecture, and this is one of the bad things.
It got me thinking about my full-time employees.
الصوت بس مش طالع يا جماعة.
To survive on $8 an hour.
Anyway, هم قلدوا صوت أوباما وطلعوا فيك ديب فيكس بكلام هو ما قالوش خالص، فكانت الديب فيكس دي بالنيورال نتوركس. لما دكتور سامي هاشم اتكلم عن الجريمه عملوها مع رئيس الولايات المتحده الامريكيه، وعملوها مع عبد الحليم حافظ غنى لبنت الجيران. احنا كنا اتفقنا ان الصوت يطلع يا جماعه.
Some progress, at least within
The deep fakes also affect the decision of plastic surgery. We must, this advertisement sometimes affect the society. When the patient, when I do some modifications in the video or the photos, the girls and the ladies will be impressed by what happens in the videos and the photos, which is not real in our surgery. So they are going every now and then for more plastic surgery. This is our dreams. We need that the AI can help us in the marketing of our patients. As in Hollywood they said, can AI replace actors in movie? Also, this is the job loss Dr. Omar Farouk said about it. I think it will not happen. AI is unlikely to replace human surgeons in the near future, but it can augment and assist them in various ways. The mobile phones you have in your hand can simulate your voice, and you can write to him, and he sent a voice note which he did not use, you didn't speak. And this is, I saw while I was going a new expression. Thank you very much.
شكرا جزيلا دكتور وائل بيه على very nice lectures. واضح ان الاي اي في الفاسكولار والبلاستيك سيرجري في كل السيرجري. الاستاذ دكتور وليد غريب مدرس الجراحه العامه في طب قناه السويس هيتكلم بقى في الجنرال سيرجري الرول اوف اي اي ان diagnosis اوف acute appendicitis والتريتمنت بقى يا دكتور وليد.
Assalamu alaikum. First of all, I would like to thank our chairpersons and the president of the conference, Professor Ahmed Sa'a, for this kind invitation. And today I'm going to talk about the role of artificial intelligence in diagnosis of acute appendicitis. Let me concise in this lecture about our own work rather than others' work, which will be, I think, is something is beneficial, and we should be proud to have it in our own university. Let me seize the chance to talk about the AI journey in our surgery department. In 2019, when I was in China, I got some collaborations with my Chinese colleagues, and this research was done using some machine learning techniques to expect the response to the new adjuvant chemoradiotherapy in colorectal cancer. This research has been published in the USA during the American Society of Colon and Rectal Surgeons annual meeting in United States. And then we succeed to build our own work in South Carolina University Surgery Department with some colleagues from Mansoura University, talking about how to expect the GERD symptoms after bariatric surgery. And this research has been published in obesity surgery during these 2 years. Last 2 years have been cited more than 30 times, and we have been mentioned by the Bariatric News in the UK. In 2022, we have collaborated with some colleagues in Annam University in South Korea, and our university was a leader for this work. We have done some researches to expect the mutation or the molecular background of cancers, rectal cancer cells, only from getting the images of the H&E stains without doing any further laboratory investigations. And this research has been published in the American College of Surgeons. So in 2023, we also get some collaborations with a good reputation of our team in South Carolina University, with the Aiken School of Medicine and the Mayo Clinic in the US. And this research was talking about how to use the AI to take a decision about the optimal incision for TATME. And we have published this article in the Journal of Vascular Surgery. Regarding our topic today, I'm going to also use our own work, but I need to say first that acute appendicitis is one of the most common surgical emergencies, and diagnosis of acute appendicitis can sometimes be challenging, and negative appendectomy remains the major concern associated with additional morbidity and greater healthcare expenses. So reportedly, we have about more than 30% of cases of appendicitis are misdiagnosed, relying on the clinical features, and may only increase the rate of negative appendectomy. In 2021, we started our project to develop an AI-based platform which is called Query Appendicitis. Developing the Query Appendicitis platform was built up using data from prospectively maintained database, and we have pre-processed this data to be compatible with the machine learning process. And we have divided these data into 70% for the training data set and 30% to do some testing data set, or what's called internal validation for this platform. After that, we have deploying this platform into 3 forms to be available for everyone, into a web application and Android application and a desktop application, using some variable or some questions as it's shown in this slide. It is very simple and very friendly to be used by everyone. And we started to make some collaborative channel with other colleagues in and other countries, and we succeeded to get some colleagues from United States, from Spain, from Italy, from China, and from Saudi Arabia to validate this AI platform and test it whether it is really accurate and can be generalized in these countries or not. During this work, we have examined patients in the last 5 years who operated for appendicitis and got a post-operative pathology to confirm whether were really true appendicitis patients or negative appendectomy. And out of this is 2,579 patients were included. We use this cohort of patients in 2 ways. First, we go directly to test the AI platform, and second thing, we use it using what is called generative adversarial network. This is simply the ethical phase of the deepfakes, what is called by our professor before me. Deepfakes is not only used with unethical issues or something like this. We also have an ethical phase of the deepfakes, like synthetic data to, if we have some rare diseases or something like this, and we don't have enough data to build a AI platform, we can get this real data and augment it and got some synthetic data. This synthetic data, to be used for research purposes, have to be tested for the quality, which like the field distributive stability, field compatible stability, and something like this. I don't want to go further for this methodological talk. So the performance of query appendicitis platform was very impressive. As we earlier said, that the main purpose of using these different scores is to reduce the rate of negative appendectomy, and our current AI platform now shows a negative predictive value of 98.7%, which means that each 100 patients operated for appendectomy, the negative appendectomy rate would be only 1.2%. When comparing our AI to the CT, we can see that we have a higher sensitivity in favor of CT. CT is 100 and the AI is 90.2. And this means that the AI platform performs better than the CT at identifying the true negatives, but not as good at identifying the true positives, and thus continuing learning the AI platform is still important in our future plan. So when asking the clinical impact of the query appendicitis platform, we have tested the clinical impact for our platform using the clinical impact curve analysis and the decision curve analysis, which are major developments in analyzing the clinical decision making models. And depending on the analysis of these curves, if we have cases with a 50% risk to appendicitis, the AI platform would manage to reduce the number of appendectomies by 986 per 1,000 patients. And thus, appendectomy would be recommended for only 14 patients, and 12 of them would be actually or true positive acute appendicitis, which reflects a very good impact on the AI platform on the clinical practice. Accordingly, the use of the current AI platform in clinical practice is expected to reduce the rate of negative appendectomy to 0.2%, which is a very promising, yet needs to be assessed during randomized clinical trials, which is our future plan, and we already take steps on earth for these clinical trials, and within 2 or 3 months we will start to establish these trials indeed. We have some message to take home from this work. First, the present study internationally validated this AI-based platform as an efficient and accurate tool for diagnosing acute appendicitis, and thus can be a valuable tool in clinical practice. The AI platform had a comparable performance to CT scanning, with the advantages of being readily available, affordable, and free of any radiation hazards. The high negative predictive value of the platform in both men and women may have excellent guidance in patients with early symptoms who may be treated non-operatively with antibiotic regimens. The AI platform performs better than the CT at identifying the true negatives, but not as good at identifying the true positives. Thus, continuing learning the AI platform is still important in our future. And thanks for your attention. We are inviting you to collaborate with us in any AI-related research in the near future. And this is my contact. And thank you again for your attention. Thank you.
Thank you, Dr. Waleed, for this interesting presentation. And now, Professor Essam Ayiad. He's a professor of pathology, former head of the pathology department, Faculty of Medicine in Cairo University. He is a member of the Professors and Assistant Professors Promotion Scientific Committee in the Egyptian Ministry of Higher Education. He is pioneer in the digital pathology and telepathology. He is a supervisor and consultant of the national program of the digital pathology in the Egyptian Ministry of Health, and pioneer in applying the digital pathology in the Egyptian universities. And now, Professor Dr. Essam will represent adoption of digital pathology and artificial intelligence challenges and future considerations.
First of all, I'd like to thank you very much. شكر خاص لسيادة العميد chairpersons for your invitation. It's a pleasure for me to introduce my experience in pathology digitalization and the adoption of digital pathology and artificial intelligence as a challenge and the future consideration. Just take a brief idea about the importance of imaging in pathology during the steps of examination of pathology gross microscopically reaching the diagnosis. We can get a lot of images, which is treasure for us for all the researches. And it was found in previous experience and the study that more than 70% of the records for any patient coming from the pathology slides. So it's very important to use this material as much as we can. But the old name for digital pathology in the past was the telepathology, which was more common to be used. But in new era, we are using the pathology digitalization. And I mean by the digital pathology, the examination of the slide on a monitor rather than the ordinary microscope. And in another explanation or definition, it's the application of all the computer sciences in pathology. Actually speaking, the digitalization of pathology and telepathology began so early in 1960s, but for a lot of reasons, it stopped for 30 years and began again in 1990s. And we have now many conferences organized only for digital pathology. And the last one was 2023. The history of the digitalization of pathology began so primitive in the using different techniques like the static one, just to take photos to be sent to another center. Then the dynamic one, we can examine the slide simultaneously between two centers, then making the combined work together. And the actual beginning of digitalization of pathology is the whole slide image. The whole slide images is a technique can take all the visualization of the slides by using this scanner. And we have a lot of scanners nowadays. This slide scanner capable to make a reading of the barcode of the slide, followed by automatic capturing and compressing the whole slides. If you can imagine that we can take, or this machine can take about 10,000 images from each slide within less than 2 minutes. And all this material will be stitched together to make a big file, then to be compressed. And nowadays, the machines, these scanners are very fast. It also gives us the capability, or the examining doctor, to see the whole slide at the same time, navigating within the slide as much as he can, going to different magnification, similar to what happened during examining the slide with a microscope. And from this point of view, we can make an archive, digital archive of all the slides we have to make a digital library for teaching, for education, for everything you want. And we can use also archiving for the whole treasure of slides we have in all the departments, faculty department. And I think the actual beginning of the digitalization of pathology and telepathology began with the use of the whole slide images for education, for network consultation, and for quality assurance. And it's used for routine surgical pathology, second opinion, expert-to-expert consultation, quality assurance, distant education, and even for frozen section studies. If you see from this picture that this is the workflow done in some centers, that all the slides coming from the lab going directly after preparation to the scanner. And by the morning, we can see the slides either to be glass slides to be examined by the professors of pathology or to be archived in the digital form. And the pathologist has to choose which type of examination he wants. He wants to examine the slide on the microscope routinely or to examine the slides on a monitor which is present already. And we began our usage of these whole slide images in the Pathology Department, Faculty of Medicine, Cairo University in 2009. And I think most of the audience are aware about the Qasr Al-Aini hospital and place. And this is our scanner. And we began to apply or to use this scanner in different ways. The first was to create a library for the students examining or scanning the whole set of teaching slides we have to be a library for us, used for the routine learning in histopathology and for e-learning. And we create this website, it's free of charge to anyone to go to it, to see the whole set of slides used for teaching of the medical students. And this is a website for us, and we expand our experience to our neighbors in histology department to create or to scan all this set of material. And this is a set of slides for the histology department we are using now for education. After that, we make a publication about the education for medical students using the whole slide images in Egypt as a country of limited resources. And it was introduced in many conferences international and was published. And it was not strange for us that a lot of citation happened and occurs for this publication, because it was a good model for applying the whole slide images and digitalization of pathology in teaching for medical students. And if you compare between the large number of students, medical students we have, and the overcrowdedness of the students in the labs, in comparison to see the slide on a monitor, in big labs, on computers, even on smartphones, to be examining the slides and in the same time to be passing through the exam directly online, no need to attend this exam physically. Then we make a digital scanning of the precious material we have of slides. We have a very good examples of slides as a teaching and faculty hospital. We have, during the past years, a lot of very interesting cases, which is very rare to be happened or to be collected in somewhere. And we began to make a digital e-library to be present and to be available for all the students. I mean the postgraduate candidates for the master and the MD students. And by the way, when we are using these whole slide images, we're trying to change what is called the quality of the slides, because the machine can detect a major errors in the slides itself. So we began to correct even the processing material, the procedure for preparing the slides to be fitting for this digitalization. After that, we went for teleconsultation. And we found that we have till now 3 centers having this whole slide image technique or the slide scanner. The Faculty of Medicine, Cairo University, the Children's Cancer Hospital, and the Military International Medical Institute Hospital. And we are trying to make a cooperation for this digitalization between us. And this opened for us a new project. I hope it will be applied this year to make a network between all the cancer centers distributed all over Egypt to be connected with a central lab for examining the slides and making a decision or diagnosis for the patients within hours instead of weeks or months. What happened nowadays for any consultant of pathology have to travel to another governorate to stay there and to examine the slides, and then asking for recutting of the slides. It will take a lot of time, but it's very easy to have a scanner in these remote areas and to be examined, to make a scanning of the slide, to be sent up to a central lab where we have a lot of pathologists in the center to be examined, to examine the slides immediately, and after also hours, we can send the final diagnosis of our slides. Also, we try to make an international collaboration with different centers for more specialization and to take opinion in our cases. And we began in our university to make a cooperation between us and St. James Hospital and Leeds University. And we make a very good collaboration, began in 2014 till now. We consulted a lot of cases, especially in the specialty of the neuropathology, and it was very successful. Also, we are trying to make a local network between the Arabic countries, surrounding Arab countries, because as we all know that there is a market shortage of pathologists in our neighbors in Arabic countries, so we can cover this defect. And according to the new progress in this digital pathology, it was good enough to know that the FDA approving the usage of the digital slides for consultation and after that for primary diagnosis. So we have a lot of advances in this technology. First of it is using the artificial intelligence and deep learning. And actually speaking, without digitalization, no way to apply the artificial intelligence in pathology. So the actual beginning was the digitalization. And we have a lot of items to be applied here. For example, we're using the different programs to examine the slides or different cuts of the slides with different stains, special stains, immunostains, to be examined at the same time to make a navigation. And I'm sure that for the pathologists attending this lecture, they will be aware about the importance of examining multiple slides with different immunostains, for example, in cases of lymphoma, to see the positivity or negativity of the malignant cells, to take a decision and to be aware of the final diagnosis in a very short time. More of that, we faced problems in taking a decision for the positivity or negativity for some cases using the immunohistochemical studies. And this was important for us. For example, in cases of cancer breast, we usually and routinely doing nowadays a panel of immunostains, including the HER2 immunostain. And according to the positivity or negativity of the slide of this case, we can decide to give this patient the proper treatment, the Herceptin, or not. And this is very expensive. And we have in pathology a cutoff which is strange for us. If we have more than 10% of the slide with complete membrane stain, we'll give the treatment. If not, we'll not give it. But it's difficult for the pathologist sometimes to take this decision. It's very easy for us using these softwares applied to these virtual slides to say if it is positive or negative in a quantitative form, not qualitative, not to be mild, moderate, strong. It will be in digits. For example, I can give this slide 90%, 50%, 30%. If I repeat the examination more than one time, I will get the same result. And we make this trial few years before, making a comparative study between the application of digital analysis for cases of breast with equivocal HER2 positivity, which is very difficult for us and a problem for all the pathologists. Comparing it with the FISH technique, which is very expensive and not present in most of the labs. And we found that the results were more or less equivalent. So we can replace this FISH technique, which is very expensive, but this digital analysis. And what's also published in many international journals. A second problem, for example, also in cases of cancer breast is the positivity or negativity for another immunostains, which is the Ki67. Also, we have a cutoff which is strange. For example, if we have positive cells, more than 14% of the cells to be positive or negative to give a decision, to give a treatment or not. It's very difficult for any pathologist using the microscope to take a decision. But with the digital analysis, it will be much easier. And we also published this publication. But this is not the end of the story. This is the beginning of the story. We have a lot of items here. We can use it. We have now softwares applied for any slide to give us a quantitative analysis for the mitosis of the slides of the cases. And very important to decide, is this borderline case or frank malignant cases? The measuring of areas of necrosis or fibrosis in liver disease, for example. Detection of the tuberculosis bacilli, the helicobacter, the necrosis in some areas, and a lot of items which is very important in pathology to decide the staging of this case. And even for the machine itself, we have a new machines with higher magnification, specified machines for cytology examination, for the immunofluorescence scanner, and even for examining or making digital slides from the fluid itself without making a slide, which is called confocal scanners. So nowadays, in some centers, they change completely the way of examination from the analog one to the digital one. The pathology labs became completely digitalized from the early beginning of receiving the case till reaching the final report. And it's used for primary diagnosis, second opinion, expert-to-expert consultation, even for frozen section where I don't have a senior pathologist to take a decision in the frozen section. It's very easy to have a junior pathologist preparing the slide, make a scanning of the slide to be sent to a central area where the senior pathologists are available to take a decision during the operation within minutes. And even for distant education and the quantitative assessment of the immunohistochemical studies. So I believe that the change and the progress in the microscopic way of examination from the very old microscopes to the present now, it took about 400 years. But the change for the digital pathology, I think it will take less much time. Thank you.
شكرا جزيلا دكتور عصام على المحاضرة الشيقة جدا، وهتبقى إن شاء الله آخر محاضرة في السيشن بتاع النهاردة. بس نيابة عن البانل إن أنا بشكر جدا الهيئة المنظمة للمؤتمر، وبشكر أستاذنا الدكتور أحمد السقا على هذا المؤتمر القيم. استفدنا جدا من المحاضرات سواء امبارح أو النهارده، وان شاء الله يطلع المؤتمر بريكومنديشنز مصر كلها تعمل بيها. دلوقتي احنا في حاجه في محاضره، لا في الدعاء ما انا هقدمها. فاضل دلوقتي ان شاء الله اخر محاضره لينا استاذه الدكتوره دعاء السيد، استاذ الكلينيكال باثولوجي في كليه طب جامعه السويس. دكتوره دعاء دايما مشرفانا في مؤتمراتنا، هي بتجيلنا على طول قناه السويس واحنا بنعتبرها عضو من عندنا. هي بتشتغل فلو سايتومتري فيزيتور كونسلتنت في مستشفى الاطفال للاورام 57-357. دكتوره دعاء حاصله على جائزه الدوله التشجيعيه، وهي اول واحده اعتمدت مركز للفلو سايتومتري في الشرق الاوسط يحصل على الايزو. اتفضلي دكتوره دعاء. المحاضره النهارده ان شاء الله artificial intelligence integration into clinical flow cytometry.
شكرا لحضرتك وشكرا للمنصة الكريمة، وأحب أشكر طبعا أستاذ دكتور أحمد على الدعوة الكريمة للمؤتمر والفكرة صراحة الرائدة. أنا عارفة أن أنا آخر واحدة فهحاول أمشي سريعا. الحاجة التانية أن طبعا أنتوا أكيد سمعتوا في خلال يومين حاجات كتير، يعني Artificial Intelligence والimportant بتاعته والتايبس والبروسيسنج، فإحنا هنحاول أن ده نجرو يعني نمشي فيه بشكل أسرع. أنا كمسمى عام أو كديفينيشن ممكن تكون سمعتوا أكتر من ديفينيشن للارتفيشال انتليجنت، لكن هو باختصار شديد جدا هو بيحاول يحاكي الذكاء بني آدم. يعني هو عايز يحول الهيومن انتليجنت لماشين 1، فبالتالي هو عبارة عن بروسيسنج، والبروسيسنج دي زي ما الكل تفضل وقال ان هو بيدخل انبوت علشان يطلع الاوتبوت. بالنسبه لنا هو الاساسي في الارتفيشال انتليجنس واللي بيخليه يختلف عن فكره الديجيتاليزيشن اللي احنا بقالنا سنين جدا شغالين فيها، هي فكره الميكينج ديسيجن. يعني هو عايز يخلي الماشين هي اللي في الاخر اللي تاخد الديسيجن. ده غالبا بيكون من خلال مالتيبل تكنيكس، اشهرهم والاغلب هو كان فكره الماشين ليرنينج، وده اللي بقالنا سنين اعتدنا عليه. لكن بعد كده ابتدى يظهر حاجه اسمها ناتشورال لانجويج بروسيسنج والكمبيوتر فيجنز والروبوتكس. ماشين ليرنينج فكرته هو ان بيدي داتا للماشين، وده كان اغلب الشغل حتى اللاب عندنا هو الفكره دي، ان هو بيدي الداتا. ومتهيألي حتى برضو الكلام اللي اتقال كتير في الراديولوجي كان نفس القصه، وهو في الاخر بيدي الديسيجن بناء على الداتا دي. اغلب الديسيجن دي كانت في ايرا ولحد يمكن فتره قريبه لازم تكون سوبرفايزد ليرنينج، يعني حتى الداتا اللي بتدخل تبقى سوبرفايز، والديسيجن اللي بيطلع برضه بيكون سوبرفايز. طبعا هو ابتدوا يطوروا شويه ويخلوها ان سوبرفايز، يعني الماشين هي اللي تدي الديسيجن، او تبقى ري انفورمنتس، يعني بيحتاج ان كل شويه ازود له الانفورميشن. مع التطور في البروسيسنج ابتدينا نلاقي حاجه اسمها ناتشورال لانجويج بروسيسنج، ودي متهيألي كلنا بنشوفها. فكره ان الاله نفسها تتعرف على الصوت وتشتغل بفكره نبره الصوت نفسها، فما تشتغلش غير بالجزء ده. انها كمان فكره مع الكلام نفسها تبتدي تريكوجنايز ده وترانسليت وتديه كمان باكتر من لغه. التطور بقى زاد اكتر واكتر لما فكره ان هو مش بس بياخد بروسيس ويدي ديسيجن، مش بس كمان بيقدر يتعرف على الصوت وكمان يترجم، لا كمان ابتدى نقول ان البني ادم بيتحرك. فابتدت بقى ان هم يشوفوا فكره الروبوتكس نفسها، والارتفيشال انتليجنت ابتدت تديزاين بيلد والكنترول الروبوت بحيث ان هو قال لك يضاهي الانسان في كل حاجه. والامور وصلت اكبر بقى كمان لما قال لك كمان مش بس هيتعرف على الصوت وهياخد قرار وهيتحرك، لا ده كمان يقدر يشوف ويتعرف على الصوره نفسها، ونشوف الريكوجنايز ده ويشوفه. ده كمان يمكن ابسط حاجه احنا بنشوفها في الموبايل نفسه، ان هو بيتعرف على الصوره او فكره البصمه الوش وكل الكلام ده كله. طيب احنا الامور دي كلها بتتطور وبشكل كبير جدا، ودي الفتره الاخيره اللي خوفت الناس، بس هل هي ليها اهميه؟ طبعا احنا زي ما اساتذتنا كلهم قالوا هي الفكره بتعتمد على الداتا، واحنا كل ما بيجري بينا العمر الداتا بتبقى هيوج جدا. مفيش بني ادم هيقدر ياخد كل الداتا دي كلها يستوعبها ويقدر يطلع بيها اي حاجه. فبالتالي كانت فكره ان يبقى في decision making مبنيه على الماشين ابتدت تبقى فيها requirements، والrequirements دي بتزيد وبتزيد. الاهم كمان مش بس فكره ان هيوج داتا وبتتحط، وده يمكن احنا اكتر بنشوفها في اللاب اكتر ناس، هي فكره ان البني ادم نفسه لما بيعتاد انه بيريبيت التاسك اكتر من مره، فهو انه يوصل لفكره الاكيورسي وان الحاجه كل ما يعيدها تبقى ذا سيم، وده كلنا عارفينها طبعا في فكره الكواليتي وفي اللاب بالذات بتبقى صعب جدا. صعب جدا انك تقول للبني ادم يعيد نفس الحركه بنفس الكيفيه بنفس الطريقه 100 مره او 1000 مره ويطلعها بنفس الاكيورسي. فبالتالي الماشين كان في الوقت ده بقى الامبورتنس بتاعته فكره الارتفيشال ان هو يعمل النقطه دي. هو ما عندوش اي مشكله خالص الماشين انه يريبيت التاسك عدد مرات مهوله جدا بنفس الاكيورسي بنفس الكفاءه. فبالتالي بعد ما كان في ناس بتقول artificial intelligence في جزء اللي هو الويك artificial intelligence اللي احنا كلنا بنتعامل معاه يوميا، ويمكن ولادنا كمان فكره ان هو بيلعب مع الكمبيوتر. هو بيبقى هو واحد من الجيمر والكمبيوتر هو الثاني، وبنلاقيه ان هو ممكن يفوز عليه مره وممكن مره لا. دي زي ما نقول ده الويك artificial intelligence اللي هو مجرد ان هو بيكون جزء اخر. لكن طبعا الامور ابتدت تبقى لسترونج artificial intelligence وان هو يوصل الامور للروبوت، وده كان اول مره كان في 2017. وكل ده كان من خلال مين تايبس اساسيه. هو انه بيعتمد يا اما على ان الماشين ده يبقى رياكتيف، ان هو انت بتقول له حاجه في نفس اللحظه هو بيديك ديسيجن ميكنج ليها. بعد كده بقى لكن ده مجرد ما انت تقفل الآلة دي او الموضوع يخلص هو خلاص انتهى. لما تيجي تتعامل معاه تاني هتبتدي برضو انت بناء على الحاجة اللي هتقولها له هو هيدي القرار. فابتدت الامور تبقى فيها another types، هي فكرة انه يبقى فيه memory، ان هو بيبتدي هو نفسه يكون experience، والميموري دي تخليه في المرة اللي وراها يدي decision اكتر. ويمكن برضو ده بنشوفه احنا في الحاجات السريعة كده، زي ما كلنا بنتعامل مثلا بالجي بي اس مثلا. كلنا بنلاحظ ان احنا لو اعتدنا على طريق معين واخترناه بناء وكنسلنا بقيه الاختيارات هنلاقيه هو تاني مره هو بيطلع لك ده اول اختيار، لان ابتدى هو يديفلوب ميموري. بعد كده يعني هو في الاول قال لك خلاص هو بيقدر يرياكت، دلوقتي هو بيديفلوب ميموري. بعد كده ابتدى يبقى فيه بقى ثيوري اوف مايند، هو كمان هيبتدي امتى يقول ايه، والايموشنز والاكسبيرينس والكلام ده كله ابتدوا يوصلوها انها تبقى ديفلوبد، ودي شفناها في الريبورتس. وقال لك لحد ما في الاخر عايزين نوصل للسيلف اويرنس، ده هو كمان هيقدر يبقى له قرار ويبقى كل ماشين ليها. طبعا زي ما احنا شايفين مجال كبير جدا جدا جدا، احنا مجرد بنقول عليه هنس الابلكيشنز بتاعته في كل مختلف الحياه، لكن احنا هنركز على هنا في الجزء اللي احنا شايفينه هنا فكره الهيلث كير. ولو احنا دورنا على في اي يعني لو دخلنا كده وقلنا الابلكيشن اوف اي اول رقم واحد دايما هتطلع الهيلث كير. ودي نقطه مهمه جدا، لان فكره الارتفيشال انتليجنت في الهيلث كير وزيادها في الفتره الاخيره كانت في الاساس بتعتمد على الدياجنوزز، لكن دلوقتي هم بيدخلوها في فكره البريسيشن ميديسن، في فكره الديسيشن ميكنج، في فكره الثيرابي، في فكره السيرجري. ودي زي ما نقول المشكله الاكبر او التشالنج الاكبر، لان هنا احنا بناخد فكره الماشين ليرنينج اللي احنا قلناها كبروسيسنج اساسيه، بس في الجزء الهيلث احنا بنعتمد على الداتا معقده اكتر. في الجزء الهيلث احنا هنا محتاجين حاجه اسمها نيورال نتورك، كميه النتورك كده بتشبهنا بفكره النيورال سيلز اللي هي الداتا مختلفه ومتشابكه، فبالتالي الديسيشن ميكنج مش هو سكه واحده انا لو دخلتها هتطلع منه، ده هي الامور متشعبه بشكل كبير جدا. وده اللي خلاهم يطلعوا بقى من الماشين ليرنينج نيورال نتورك، وابتدوا يطلعوا منها بحاجه اسمها ديب كمان ليرنينج. فبالتالي الديب ليرنينج ده طلعنا لحاجات بتبتدي تعالج حاجات خطر جدا، واهمها فكره الكانسرس ليجن، ان انا اقدر اخد القرار واريكوجنايز ده واحطها كبوتنشال واخد القرار. ويمكن زي ما قال الاستاذ الدكتور عصام قبل ما نبتدي فكره ان احنا نحدد فين بالظبط بتنتهي المالجنسي او ان ده مالجننت او لا. ساعات الديسيشن ده ممكن ما بيقدرش عليه باثولوجيست واحد، ده احنا ممكن نبقى كونسلتنت، احنا بقى متوقعين ده يكون مع الديب ليرنينج في وان ماشين. طبعا الجزء الخاص زي ما احنا قلنا الناتشورال لانجويج بروسيسنج والكلام ده كله بالنسبه للجزء في الهيلث ناس كتير تقول انه ملوش لازمه، لكن اقول لا هو ليه، سواء كان في الجزء الخاص بالبريبير ريبورتس انه يتعرف في بعض الالات انه يتعرف على الشخص اللي هو الاوثرايزد بس ان هو يشتغلها، فبيعتمد على النقطه دي. طبعا الروبوتس دلوقتي احنا شفنا وبالذات بدايه الالفينات ان سيرجري معقده جدا ومهمه جدا ان استخدموا فيها الروبوتس، وابتدت بستخدم حاجه فيها النون انفيزيف بارت. وكلنا طبعا عارفين سامعين عن سايبر نايف وقد ايه هو كماشين بيقدر يحدد بالذات في البروسيس، بالذات في الهيدن نيك سيرجري يقدر يحدد المكان ويقدر يحدد كمان الجزء بس اللي يقدر يستأصله without any invasions. فبالتالي في الامبليكيشنز في الهيلث ورك ده لما تشعب كده الناس ابتدت بقى تقلق، وقال لك ده هو ده هيضيع بقى فكره الورك فورس وان هياخد شغل الناس. لكن على الاكشوال المفروض ان اكتر ناس كانوا يخافوا من ده هم بتوع المعمل والاشعه، لان هو ده اكتر مكان دخل فيه. لكن مع مرور الزمن لقوا لا، ان ده ما بيحصلش، وان لحد دلوقتي هو علشان ده يحصل هو محتاج ناس كتير تدخل الداتا دي، ودول لازم يكونوا متخصصين. ولحد دلوقتي اغلب الديسيجن ميكنج اللي بتطلع بتبقى سوبرفايزد باي سواء كان ناس من اللاب او ناس من الاشعه. فبالتالي لحد دلوقتي ما حسناش ان ابتدى يبقى يحصل فيه ورك فورس. احنا كمعمل مثلا دلوقتي كل الحاجات عندنا ديجيتال من اولها لاخرها، ومع ذلك مش ممكن ابدا تستغنى عن التكنيشنز ولا على الدكتورز، لان انت محتاج حد يدخل من اول العينه، يتابعها، يبص عليها، يعمل جزء كواليتي كنترول، يسوبرفايز ات، وهكذا. ده بالعكس كمان ابتدى الارتفيشال انتليجنت يدخل وظائف جديده ان الناس تتعلم ازاي تدخل السوفت ويرز وتتعلمها. نيجي بقى في الجزء اللي خاص بالهيماتولوجي، وليه بنقول في الهيماتولوجي بالذات الارتفيشال انتليجنت خد وضع اكبر، لان في الهيماتولوجي عندنا بالذات احنا اكتر برانش في اللاب في دايجنوزز، ان احنا محتاجين ان احنا عندنا نكولكت داتا سواء كان من مورفولوجي، سواء كان من سايتوجينيتكس، سواء كان من فلو سايتومتري، ودي داتا هيوج جدا ان انا في الاخر بطلع دايجنوزز. فان انا اوصل لميديكال ديفايس يطلع ده كحاجه واحده او حتى سوفت وير، دي بتبقى يعني زي ما نقول ايه، شغلت العالم فترات طويله جدا الفترات الاخيره. ولاحظنا كبير جدا بعد ال 2020 الامور دي ابتدت تكبر، لدرجه ان 2021 قال لك ان في 38 ميديكال ديفايس دخلت خدت الاف دي ابروفال، واحنا بنقول بدل هنا اف دي ابروفال يعني دي حاجه بتشتغل على الكلينيكال اكتر من ريسيرش، خدت ابروفال في عشان بس في الجزء الخاص بالهيماتولوجي دايجنوزز. في الآش كأكبر مؤتمر في العالم يخص الهيماتولوجي كان في السنة دي لوحدها 69 بحث بس عن الارتفيشال انتليجنس. فده يقول قد ايه في الايرا دي ابتدت الامور تكبر اكتر. وهنا بقى السؤال الاهم بالنسبه للهيماتولوجيست، انا اي لاب بحتاج فيه علشان اشتغل تيست، بحتاج له تريننج، بحتاج له فاليديشن، وبحتاج له في الاخر تيست سيتس على بعضها بقول ان هي دي اللي توصلنا لهذا. طب انا هعمل ايه في الجزء الخاص بالارتفيشال انتليجنت؟ قال لك نفس الكلام بالظبط، انا محتاجين نعمل للجزء ده تريننج بان انا ادخل داتا كتير عشان اقولها او بعمل ماشين ليرنينج للاله دي، وفي نفس الوقت لازم اعمل فاليديشن ان هو في كل مره بيشخص ده صح واعمل له كواليتي كنترول بالحاجه اللي تبقى دي مظبوطه لحد ما في الاخر اطلع لازم. لكن احنا عايزين ناخد بالنا من النقطه دي، ان هنا مع كل الحاجات اللي هو حطها ان هنا في الاخر في السنترال كل الديجيتاليزيشن دي هو في الاخر حاطط هنا ان لازم يبقى في اكسبرت ايفالويشن، انا مش قادره اعلم عليها اللي هي الجزء الخاص بهنا. فانا الميكروسكوب ممكن يشوف الخليه، ممكن يتعرف عليها، ممكن يعرفها، ممكن يحطها في الكاتيجوري بتاعها، ممكن كمان يعمل معاها اديشن لسايتوجينيتكس. لكن هو ما زلنا في الهيماتولوجي عندنا جزء مهم جدا وهو فكره الاكسبرت ايفالويشنز، ما زال في الهيماتولوجي مش قادرين يغطوه. وهنا دي نقطة مهمة جدا خاصة في الفلو سايتومتري. دايما بنقول ان الفلو سايتومتري هو هايلي سبجكتد ماشين. ليه؟ احنا زي ما شايفين الفيجرز بتاعة الفلو هنا هي كمية بوبيوليشنز وكمية دوتس كتيرة جدا، كل واحدة من اللي متلونين دي بوبيوليشن. البوبيوليشن دي انا هقول هنا ان دول بوبيوليشن يساوي مثلا مجموعه خلايا معينه، البوبيوليشن دول مالجنانت، البوبيوليشن دول بيناين. انا بناء على الداتا دي المجموعه هنا والمجموعه دي والمجموعه دي انا في الاخر باخد ديسيجن، فهي هايلي سبجكتد. انا عشان احول ده لفكره ان انا اعمل له زي الكلاسترنج او اعمل له الجوريزم، زي ما شايفين ان هو بياخد كميات كبيره جدا ان انا اقدر احولها ل الجوريزم يقدر يحدد. وبعد ما هو يعمل كل ده هو في الاخر بيقول لي البوبيوليشن دي ايه، لكن هو التوتال دايجنوزز ببقيه الكلينيكال داتا هو صعب جدا يوصل لها. فهم ابتدوا يقولوا في الارتفيشال انتليجنت خلاص احنا على الاقل نوصل لنقطه ان احنا نقلل كميه السبجكتيفيتي، الفاريشنز الكبيره جدا اللي موجوده في هذا المجال، واللي هي بتبتدي هنا من اول اختلافات السامبل والسامبل تايبس والاكسبيرمنت واللابوراتوري وكل ده. فابتدوا يقولوا ان احنا هنا هنبتدي نعمل زي ديجيتاليزيشن للجزء البري اناليتيكال وجزء الاناليتيكال وجزء البوست اناليتيكال، نحاول نوحد ده بحيث ان احنا نقدر نقلل السبجكتيفيتي والفاريشنز. مع كل التجارب اللي احنا شفناها، واحنا طلع في وقت من الاوقات سوفت وير معمول في اوروبا نتيجه بروجكت كبير جدا. السوفت وير ده بيقول لك ان انت بتدخل عليه كميه، تدخل عليه اي فلو سايتومتري ريزلتس هيديك دايجنوزز للهيماتولوجيكال ديزيز على طول. احنا اشترينا السوفت وير ده فعلا وكان بمبلغ وقدره وجينا نجربه، لانه ما ينفعش. ليه؟ لان الداتا اللي عندهم مختلفه جدا، سواء كان في الليزر، في الجهاز، في نوع السامبل، في نوع الاشخاص نفسهم، في الانفايرمنتالز اللي موجوده. فبالتالي عشان استخدمه انا محتاجه ادخل نفس الهيوج داتا اللي هو مدخلها في بروجكتس اول اوفر ذا يوروب. انا محتاجه ادخل كل الهيوج داتا دي بتاعه المصريين اللي موجودين عشان ادخل له عينه واحده يقدر يديني فيها دايجنوزس. ففضلت المشكله هنا، رغم ان هو ابتدى يحاول يحل الفاريشنز ويليميت السبجكتيفيتي، فضلت المشكله الاساسيه في فكره الستاندردايزيشن. انا طول ما انا الاول عندي لاك للجلوبال ستاندردايزيشن، هتقعد برضو الارتفيشال انتليجنس في الجزء ده ليها ليميتيشنز، لان لازم في الاول وفي الاخر اعمل الستاندردايزيشن بتاع المكان ده نفسه، يعني احط الداتا الخاصه عندي واعمل لها ستاندردايزيشن عشان اقدر اوصل للتشالنج او الاريا بتاعت النيز بتاعتي لفكره ان انا اوصل للكلينيكال ديسيجن ميكنج واقدر اعمل لها structures. نرجع تاني نقول هي تشالنج، بس هو في الاول وفي الاخر اتس نوت ا ماجيك. هو الارتفيشال انتليجنت از ا ماس، ونفس الكلام الفلو سايتومتري از نوت ا ماجيك. فهو تشالنج، ولكن هو ده اريا كبيره جدا ان احنا نقدر نوصل لها، بس طبعا مع دايما نبص في الاطار بتاع الايثيكال امبليكيشن اللي طبعا من امبارح الناس كلها اتكلمت على الجزء الخاص بالايثيكال امبليكيشن، لكن في نقطه مهمه جدا ناخد بالنا منها، فكره الاكاونتابيلتي. احنا كلاب، احنا لما بنشخص حاجه ده دايجنوزز، لو في خطا بتحاسب المخطئ. طب انا لما انا اقول دايجنوزز واقول ان ده تشخص كانسر وفي الاخر طلع غلط، هنحاسب مين؟ مين اللي هيتحاكم؟ الماشين؟ وده متهيألي من الحاجات المهمه جدا في الايثيكال امبليكيشن، سواء كان فكره الاكاونتابيلتي او ترانسبيرتي اللي محتاجين في التشريعات الناس تبص عليها. في نقطه جدا مهمه جدا برضو بتلمس الانسان، هي فكره البيشنت هو will inform him by diagnosis. احنا هنا لما بنيجي ندي خبر زي ده العيان بتبقى مشكله كبيره جدا. هل هيبقى ethical ان diagnosis او clinical decision يقولوا ماشيين لبيشنت؟ كل النقط دي طبعا هي دي الشالنج في الفتره اللي جايه. and thank you، ويعني اهم حاجه ما كنتش طولت عليكم.
شكرا لحضراتكم. والآن مع الجلسة التاسعة للمؤتمر الخاصة بعروض الأبحاث، فليتفضل رؤساء الجلسة: أستاذ دكتور محمد شعبان، أستاذ دكتور مجدة إبراهيم، أستاذ دكتور محمد حفني، أستاذ دكتور محمد صالح،